So rest of the delegates would be in they would be on muted, right?
Yes, so participants won't have the chance to speak, but if they
Okay.
have any queries, they can mention their queries in the chat box.
Okay. So basically, it would appear in this
We
question
have
and
a
answer
file
session, right?
open your one PPT.
So it appears in the chat box, so rather than Q&A section, it appears in the chat box.
Okay.
I think Dr. Milap sir has joined.
I guess sir has joined with your link itself, sir.
Yeah, actually, I sent it. Can you rename it, please?
Yeah, I'm renaming her.
Milap sir, you're there, sir?
Yes, sir. We have renamed it, sir.
Roshni, can you reach out to Dr. Priya and Dr. Sunil once again?
Okay, sir.
Milap sir, just can we have just one test, like your audio and video? Good evening, Dr. Sunil sir. Shrikant from AstraZeneca again.
Dr. Tiwari ma'am will be joining in 2 minutes, sir.
Thank you, Roshni.
Hi, Mila.
Can you hear me?
Yeah, am I audible?
Yes, yes, yes. Hi, Sunil. How are you?
I'm good. How are you, Mila?
Fine, fine.
You are still in hospital?
Yes, Saturday.
Yeah. Even we are working on Saturday. Like I just reached 5 minutes earlier.
Okay. How is the weather in Delhi?
Yeah, it's hot, but infrequently, we are getting some irregular. There is some rains are there. But overall, it's hot. Once in a week. Now the monsoon is not that consistent actually.
Maybe now you should visit
Dr.
Hyderabad right
Sunil
now.
sir, the Shrikant here from AstraZeneca. Your voice is clear, but bit low side.
Pardon?
I'm Shrikant from AstraZeneca. Your voice is
Hi.
clear, but it's bit low, sir. Can you just put
It, it,
the mic or something?
it's been
It is bit low volume.
low.
Yeah.
Okay. Can I put it on this headset?
If possible, you can, sir. Otherwise, it's okay, sir.
Any improvement is there?
Now it's clear, sir. It's very good. Loud.
Right. So now it's clear. Great.
Yeah, it's very good. Right, loud, sir. Thank you, sir. Thank you.
Hi, Dr. Sushant. Am I audible?
Yes, you're audible, sir. You're audible well.
Oh, yeah.
Hi, Dr. Soumya, you're audible.
Hi. Good evening. Sorry, I'm actually out of station somewhere else right now.
Shrikant, let me know when we are supposed to start.
All the speakers joined.
Yeah, Dr. Priya also joined.
Good evening, Dr. Priya.
Good evening.
Nice to see you after a long time.
I can't see you.
Oh, my. Okay. Yeah.
Oh, yes. Long time. Really, really, really long time.
After a long time.
Listen,
How
sir, we can start, sir,
Yeah, we can start. Okay, let's start.
since we have all the facts.
Yeah.
Yeah, Shrikant, should we start? It is
Yes, sir. Yes, sir.
exactly 7.
Yes, sir. Hello, everyone. Very good evening. Welcome, everyone. Thank you for attending this webinar. I would like to invite Dr. Sushant Vinekar for setting the content and take the event forward. Sir, over to you, please.
Hello, everyone. Good evening. On behalf of Molecular Pathology Association of India, I warmly welcome all the esteemed faculties and delegates to this educational webinar. MPI has consistently strived to provide educational initiatives that reflect the evolving landscape of academic diagnostics and therapeutics. I'm pleased to share that while in 2024, several of such academic engagements have been completed by MPI, today marks the first of our webinars in 2025 on HER2 scoring and interpretation in solid tumors. We all know that the field of oncology is in always a paradigm shift from one fits all approach of therapy to personalized treatment, or I would say a personalized targeted therapy approach, which is guided by molecular alterations. This transitions places a renewed emphasis on precise biomarker testing, especially HER2, which is now gaining relevance across a growing spectrum of solid tumors beyond breast and gastric cancers. Let us learn what are the new updates in HER2 testing in solid tumors beyond breast and gastric cancer. I would request all delegates to kindly post their questions in the chat as the talks progress. We will address them during the question answer sessions at the end of the webinar as the time permits. So, for the first talk, we have Dr. Priya Tiwari, who is a leading medical oncologist from Artemis Hospitals, Gurgaon. It is my pleasure to invite Dr. Priya, and she would be highlighting the management of HER2 positive solid tumors. She would cover the treatment options and the emerging antibody drug conjugates that are transforming the therapeutic landscapes in HER2 positive solid tumors. So, over to Dr. Priya. Please go ahead.
Thank you, sir. It's a really nice platform for this discussion. Now, even we are learning a lot about the HER2. Yes, and rightly said, the world has moved beyond breast cancer, beyond gastric cancers. We have just so many cancers. We are now routinely performing HER2 testing. And the NGS has also come into role now, and we are learning that how to actually qualify a patient as HER2 positive tumor or not, because the definitions are also changing. So I'll just start sharing my screen and deal with the clinical aspect of it. So I think the slide deck is visible.
Yes, Dr. Priya, it is visible. Can you
Okay.
put it on screen? Yeah, now
Yes,
it is
yes.
completely visible.
Okay.
Yes. Please go ahead.
Yes. So as rightly said that previously we were just limiting ourselves to breast cancer. Now, when we started treating breast cancer, the history evolved that we did not know that HER2 positivity actually made a difference even in the breast cancer patients. Now, but then subsequently the drug called as trastuzumab came into play, and it showed that yes, it improved survival, both in terms of PFS as well as overall survival. It actually doubled all the figures by more than 50%. It actually doubled it. But what we also learned that the patients who were ISC 3 plus or if ISC 2 plus but positive by FISH, those patients only responded to trastuzumab and showed a clinical benefit. So that is why we labeled the patient as we looked at the ISC scoring and the FISH scoring, because the therapeutic relevance to trastuzumab as well as the other HER2 targeted therapies such as the TDM1, tucatinib, neratinib, lapatinib, pertuzumab, all they were limited to the ISC 3 plus in the breast cancer by and the FISH positive patients. In the case, the ISC was 2 plus. So that is what we were, for a very long time, we were just limiting ourselves to these kind of definition. But slowly the data also came for other tumors, as you can see by this slide deck. TOGA was the trial which established that the stomach cancer also, the gastric cancer also showed the HER2 expression, though the heterogeneity was much more compared to the breast cancer, and there were difference in the measurements too. So beyond breast cancer, we also learned to measure HER2 expression in the other tumor, and the story started from the gastric cancers. But now we are standing at many other cancers where we are seeing that yes, HER2 expressions are seen, the HER2 protein expression where it can have a therapeutic relevance. Beyond HER2 protein expression, the NCCN, the guidelines that we tend to follow, and beyond amplifications, we are also seeing NGS based amplification in HER2 mutations also. Specifically in lung cancer, where NGS based HER2 mutation actually helps to decide your treatment algorithms, especially in the patients who have progressed on first line therapy. In breast cancer, in serous or endometrial cancers, and in this stomach cancer, we have data of first line HER2 targeted therapies. But beyond that, we have recommendation is still either in second line or beyond. But yes, not only non-small cell lung cancer, but colorectal cancers, biliary tract cancers, bladder cancers, ovarian cancer, cervical cancer, pancreatic cancer, and various other tumors, especially salivary gland tumors, are the ones where now the data is evolving, and we have started using at least one or more form of HER2 measurements. And we are not just limiting ourselves to HER2 protein expression or amplification. The HER2 mutation NGS is also taking a big role. But the problem with the HER2 mutation in our clinical practice is we still don't know how to therapeutically target HER2 mutations. We have data of certain drugs such as TDXD now coming in big way in these tumors, especially in lung cancer and in various other cancers, especially in HER2 mutated tumors. Now in colorectal cancers, in breast cancers, we are now, so in breast cancer, if I were to give you an example, which is where the whole scenario is actually established, we treat patient either with just trastuzumab or a combination of trastuzumab with pertuzumab with chemotherapies in the first line. In breast cancer patients respond very well to a single HER2 targeted therapy also. But that is not the case with colorectal cancers. We have seen that patients, if are just given benefit of single HER2 target therapies, these patients, they don't derive benefit. So especially in colorectal cancers, the guidelines recommend now, and that is what we are using in our clinical practice, using a combination of dual HER2 blockade. So that is what you can see from this slide, the pertuzumab lapatinib combination. Both of these are HER2 targeting therapies, or in either with combination of tucatinib. And yes, we have TDXD. Now the introduction of TDXD to the medical world actually changed quite a lot of things. It also showed that the trastuzumab was only working where ISC was 3+ or where there just was FISH positivity. But the data for the TDXD has come especially in breast cancer, what is like HER2, ultra low, HER2 low. So any expression of HER2 we have seen, especially in the breast cancer, patient will respond to TDXD. Now TDXD is a class of drug, what we call as the antibody drug conjugate. So all these targeted therapies, they are like monoclonal antibodies, but TDXD has a very unique structure that it has a drug and antibody both combined together in a single molecule. These drugs also have some kind of modifying effect over the tumor microenvironment. So they are able to exert anti-cancer effect even with the minimum of HER2 expression. So we have other antibody drug conjugates also like TDM1 especially in breast cancer and other HER2 expression tumors. But TDXD is something where a lowest possible amount of HER2 expression, especially in breast cancer, can also exert the anti-cancer effect. And that's why the TDXD data is coming across various cancers. So you can see even in lung cancer, colorectal cancer, biliary tract cancers, endometrial cancer, bladder cancers, ovarian cancer. Ovarian cancer is one cancer where we generally don't see HER2 expression. But here, if there is HER2 expression, then yes, again TDXD is a therapeutic option. So wherever you can see a HER2 expression, especially a strong HER2 expression, the TDXD has now come in as one of the therapeutic options. So this is where now the data is evolving, and now we are doing HER2 testing in usually most of the solid tissue cancers. This is the NCC, and the other guidelines are also recommending on the similar lines. Now the challenge is many of the cancers don't show a lot of expression of HER2. Like we have started routinely doing HER2 expression across all the tumors. So we do ISC, and at some point of time we are going to do NGS also across all the solid tissue cancers, because we want to have more information about the tumors. So the NGS practice has actually evolved a lot. But yes, the ISC expression is not that common. If I were to share my data, we have actually tested the last 300 consecutive cervical cancer patients, and we have found 7 patients having an ISC expression of 3+. But that's a very small percentage, and that's the reason that the guidelines don't recommend usually doing ISC testing in many other cancers. But yes, for endometrial cancer, especially the serous subtype, the HER2 testing as well as the HER2 targeted therapy has become the standard. But yes, for the ovarian cancer, the bladder cancers, the guidelines are not generally recommending the ESCO guidelines, and we saw the NCCN guidelines or that. But yes, in our practice, we have started doing, because we see that yes, the percentage is less, but around 5 to 7% of patients can still be ISC 3+. plus, and where we can actually use some kind of targeted therapies, especially the TDXD and other HER2 targeted therapies for our therapeutic advantage. Now, this was a Destiny Pan Tumor 02. This was a study which actually established the TDXD. So you saw the TDXD recommendation across all the cancers. So this was the actually study which established the TDXD efficacy in these cancers. Now, TDXD is an injectable drug. So we also have oral TKIs, tyrosine kinase inhibitors, that work in HER2 positive tumors. So you have tucatinib, you have neratinib, you have lapatinib. These three are the oral ones, okay? The trastuzumab, TDXD, TDM1, all these are injectables. The TDXD is a bigger molecule, but still it has demonstrated its efficacy. The smaller the tablets, the lapatinib, tucatinib, the good thing is that they can actually go inside the cell. So they have intracellular efficacy. So that is why wherever we see mutations, the guidelines say that maybe those tablets you can actually prefer because they can go inside the cell that target the mutations. Okay, but the TDXD, because of its efficacy, because of its impact over the microenvironment, can be used in the mutations too. So I'm just going to show certain data for TDXD because this has actually revolutionized the way a HER2 positive cancer, based on the ISC, based on the FISH, based on the HER2 amplification on the NGS, and in certain tumor based on HER2 mutations, there is a recommendation regarding the TDXD. So Destiny Pan Tumor 02 is a phase 2 open label multi-center study. Because see, it's a small study, but it took more than 50 centers because we saw that the HER2 expression is not very common in a lot of cancers, and that is why they took a lot of centers. Where, on an average, actually, each center gave 1 to 2 patients. So this was advanced solid tumor patients not eligible for curative therapy. All the patients were actually second line and beyond. That means they have progressed on first line therapy. So HER2 expression, the patient they enrolled were either ISC 3 plus or 2 plus, but cervical cohort were expanded to have ISC 1 plus patients. Now they initially took patient with the local lab ISC results, but later on the central lab results were also taken into account to actually show you the various results and the various classification. And they have used gastric scoring to determine the ISC status. TDXD was used in the standard dosing and there are 40 patients. So you can see the patients who were taken, the endometrial, cervical, ovarian, bladder, other tumors. So in other tumors you had extramammary, Paget disease, salivary gland tumors, biliary tract cancers and pancreatic cancer. The primary endpoint was overall response rate. Now if you were to ask me, we tend to prefer overall survival and PFS as the better endpoints. But for this drug, they have taken an overall, the investigator confirmed overall response rate as the primary endpoint. Now, when we see the results, the overall response rate, certain cancers, they do better. So the question is, are the results different based on the ISC expression? So you see here in the endometrial cancer. Now in endometrial cancer, the HER2 targeted therapies, especially for the serous cancers, have come in first line. Now we see here that yes, both ISC 2 plus show responses, but ISC 3 plus shown more responses. So yes, based on the ISC expression, a difference in response is obvious. But yes, the ISC 2 patients also show a response. That is visible in endometrial cancer, that's visible in cervical cancer, that's also visible in ovarian cancers, isn't it? And that's also visible in the bladder cancers and the other tumors. So just to reiterate, the other tumors included extramammary Paget disease, head and neck cancers, oropharyngeal neoplasms, and salivary gland tumors. Biliary tract cancer also showed a response, but here we see responses limited to ISC 3 plus. Now, surprisingly, the pancreatic cancer, we don't see much responses here. So maybe in the pancreatic cancer, there are other crosstalks going on, and the ISC 3 plus or 2 plus does not show a therapeutic efficacy with TDXD, unlike other cancers. So this group did not do well. Pancreatic cancer is one such cancer. We have very limited treatment option and a very aggressive disease biology. So overall response rate was 37.1, ISC 3 plus it was 61. And yes, we also had in the ISC 2 plus responses. Now when we see about the PFS, because we ultimately not just want responses, we want the patient to show, we want the patient to show the patients to live long and to show a disease control too. And again, we do see a difference by the ISC expression. So when we talk about the all cohorts, the ISC 3 plus shown a median PFS of 11.9 and ISC 2 plus shows 5.4. Now this I'm talking about a setting, I'm not talking about breast cancer, I'm talking about other cancers, and I'm talking about a setting where the patients have already taken treatment first line and the second line. Okay, so this is a later line of treatment. Now clinically, when you are a medical oncologist, you see that a PFS of a third line therapy of 5.4 months is also something that we look forward to. Okay, so in ISC 2 plus it was 5.4 months, but yes, ISC 3 plus did better. Now, the cervical cancer is something that actually has established my belief in the drug, as well as in the cervical cancer doing the testing for HER2. You see the remarkable curves, isn't it? The median, PFS is yet not reached, isn't it? And in ISC 2 plus, it is 4.8, overall 7.0. Endometrial cancers are also doing good. The median PFS in 3 plus is not reached. In the 2 plus, it is 8.5. Overall, it is 11.1. And yes, in ovarian cancer also, HER2 target therapies are showing responses and longer PFS with ISC 3 plus, 12.5. That's actually very good for ovarian cancer, because we know that as the patients progress in ovarian cancers, the disease become very aggressive, and the treatments are only chemotherapy drugs, and the patients show a very dismal outcome. The problem in the cancers are also because when we start to treat them with each subsequent line of therapy, there is more chance of the blood count to crash, there is more chance of having side effects. So we want treatment which the patients can tolerate, where the dose adjustment does not make a difference. Now the bladder cancer remarkably showed that the PFS is not different between the 3 plus and 2 plus. It was 7.4 and 7.8. But yes, for all other tumors, it did make a difference. Especially in the other tumors also, 23.4 versus 5.5. Pancreatic cancer, we saw the overall response rates, it was dismal, and the PFS is also dismal compared to the other tumor subtypes. So maybe there are other resistant pathways, the bypass pathways, which are working in pancreatic cancer, where we need to understand more. So just to give you the PFS and overall survival of all the cohorts. So median PFS 11.9 in all cohorts ISC 3 plus, and the median overall survival 21.1. See, when the patient comes and has a stage 4 cancer, from the time of diagnosis, we usually give them a median time period of around 1 to 2 years. So this is from the time of diagnosis. Now the patients have already, in this particular study, patients have already taken 2 or more line of therapies. Now usually they show response to around 6 to 8 months on one line of therapy, then they have progression, then again 6 to 8 months. And after second line of therapy, any treatment PFS is usually around 3 to 4 months, the overall survival becomes less than 1 year. But we do see here that the median overall survival with ISC 3 plus is 21.1 and ISC 2 plus is 12.2. So yes, a promising approach. See, the whole concept is we want to convert the stage 4 cancers to a chronic disease, isn't it? So by applying each subsequent and effective line of therapies, that is what we aim for. And we do see that the individual cancers show a difference in the overall survival figures also. Endometrial cancers and the cervical cancers are the one which are showing the better results compared to the other cancers also. And as we saw the difference in PFS, with each ISC expression, we also see a difference in the overall survival. Like here in ovarian cancer, ISC 3 plus, the median overall survival is 20 months, and with 2 plus, it is 13 months. And on the similar lines, the median overall survival in other tumors with ISC 3 plus is 24.3 and 2 plus is 14.6. Now, important thing is to understand the side effects. When the patient comes to us in the OPD, we know a stage 4 cancer patient, the most important parameter is the quality of life, because we are not able to cure the patient, isn't it? So that is why the safety becomes much more important. It's very common for the patients to say, madam, if I have just 6 months to live, I don't want any treatment related side effect, isn't it? You want to live that 6 months with integrity, isn't it? So the side effect of every treatment becomes very important. Now TDXD is a drug which can cause side effect. When it came in the first time, there is something called as interstitial lung disease. It can cause ILDs. This is not seen with other anti-HER2 targeted therapies, the other HER2 targeted therapies. ILD is something which is very much unique to the TDXD. Now we are also understanding that the earlier you use TDXD, the less will be the ILDs, but we are also getting a hang of how to manage these side effects. The other side effect is nausea. That is why we want to give lot of preventive nausea medicines. The drug can cause fatigue, it can cause neutropenia, anemia, especially when used in the later lines, and that is why you require supportive medicines for all of these medications. So yes, it's important to see if the patient comes to OPD and he says that I have developed this particular side effect, or I don't want to continue the drug. You have to find a way to see if the dose reduction can help and continue the medicine. So the drug-related treatment emergent adverse events associated with dose discontinuation were around 23. Drug-related treatment emergent adverse events associated with dose interruptions were around 54. So overall, it's a drug where we are now getting a hang of how to manage the side effects, and with the proper management, with the guideline-based management, we are understanding that's very much possible to decide which particular dose will suit to which particular patient. So the TDXD demonstrated clinically meaningful activity across a broader range of HER2 expressing solid tumors. But the question is, are we covering for all the HER2 targeted therapies? Are we measuring the HER2 right? Okay. So the overall response rate are 37.1 in all patients, 61.3 in patients with ISC3+. And yes, durable responses were seen. The median duration of response was 11.3 months and 22.1 months in patients with ISC3. And it led to clinically meaningful progression-free survival and overall survival with the PFS of 6.9 months in all patients and 11.9 months in patients with ISC3+. And yes, in this particular study, the safety of TDXD was consistent with the known profile. So Destiny Pan Tumor 02 supports the potential role of TDXD as a tumor agonistic therapy for patients with HER2 expressing tumors. Now coming to the lung 02, the lung is very important because here, so you have HER2 mutated tumors. So, we are doing ISC measurement certains, we are doing FISH amplifications, and we are also doing a mutation assessment. Now, HER2 mutation is very important in lung cancer. We are now seeing, as we are doing more and more NGS, we are seeing a lot of HER2 mutations in non-small cell lung cancers. This drug is actually making a lot of difference. So we have approval of TDM1 also. In lung cancer, there are 2 drugs actually approved, and all of these are approved after progression on first line of therapy. But in lung cancer, we are doing ISC. There are ISC based recommendations also, and there are HER2 mutation based recommendations also. So this was Destiny Lung 02 dose blinded randomized multi-center international. See, whenever we start using a drug, we also try to see if a higher dose will work better than the standard dose, isn't it? And maybe it will lead to better responses, sustained responses. So people try to tweak with the doses. So the standard dose is, this is 5.4 milligram per kg, but they also wanted to see if you increase the dose, what will happen. So TDXD 6.4 milligram per kg was used. The clinicians, that we tend to get greedy very easily, isn't it? So this is what was used here, trying to see if the difference in the doses will create better responses. So the primary endpoint was confirmed overall response rates with number of secondary endpoints. Now we see here, if you compare the percentages, okay, we don't see much of the difference, isn't it? So the CR rates might be slightly better, but overall responses were not much different. The disease control rates were not much different, isn't it? So actually there is not much difference in terms of the efficacy outcomes are concerned in between the 5.4 versus 6.4. So this is very important. So what I would just want to show you here. So this was the overall response rate around 56. And what is important is, whether you use the TDXD in the after the first line, second line, third line, it does not matter, okay? So with chemotherapy, the problem is with each line of therapy, if you use like some chemotherapy you have used in first line, it will be a longer response. But the same chemotherapy, if you use in second line or maybe third line, the responses grew progressively short. Now this has not been seen with the TDXD, and it's actually really a relief to know that whether you use in the earlier line of setting or in a later line of setting, the responses tend to be similar, okay? So regardless of number of prior systemic therapy, and that also applies to the other HER2 targeted therapies also. TDXD in one such drug which has a very good intracranial penetration. Now all these HER2 positive tumors, be it breast cancer, be it GI cancers, be it colon cancer, they have a very high propensity to go to the brain. Okay, so that is why we need drugs which actually go to the brain. Brain is actually a sanctuary site, isn't it? Not lot of drugs actually go, and that creates lot of nuisance in our practice because we see that the disease is controlled everywhere, but the brain actually keeps showing progression every time. So isolated brain recurrences create problem for the patients, for the clinicians. So we need drugs which actually show that they demonstrate an intracranial penetration in their responses, and the TDXD is one such molecules. The other antibody drug conjugate compared to the TDM1, the TDXD has a better intracranial penetration. Now, the similar kind of results were seen with the TDXD at 6.4 milligram dose as well. Now, when we compare the PFS is slightly better with the higher dose, 6.4. But the catch is here, the overall survival is not that different, and it's actually better with 5.4 because overall survival is also impacted by the crossovers, by the treatment-related deaths and the rest of the factors. So that's the reason even in lung cancer, the dosing recommendations remain same, and we don't see any advantage by increasing the dosing. Actually, it will actually worsen the side effects. So we see more side effects with the increasing dose. So yes, the more is not better here. So this slide concluded that the 5.4 kg, let's stop at 5.4 milligram per kg and not increase it. The colorectal cancer is again a very important cancer. The incidence is rising in India, and we know that when there is a HER2 pathway active, patient don't respond to the EGFR based treatment in colon cancer. So in colon cancer, we are still in a very preliminary state to label the patient for the to have the treatments. But yes, the data is coming. Like I previously said, here we actually used dual HER2 blockade, but TDXD has also been used here, and it has shown responses. Now they have again this was a two-stage study design. So different kind of cancers, different kind of study design. In the first stage, they actually again wanted to compare the 5.4 versus 6.4, but then later found that 6.4 has more toxicity, not much difference in the efficacy. So they just continued with the 5.4 milligram per kg body weight of dosing. So here we do see that, we compare the patients who were taken 5.4 versus 6.4. We don't see much difference in the response rates, okay? And the duration of response, disease control rate, everything is comparable with 5.4 kg, and the median duration of response was 5.5 months here. So yes, again, this is the setting where patients have already received one or more line of therapy. So we are talking about all the metastatic cancer in the later line of setting, where we don't have standard of care, where we know that the patient performance status also decreases, and the patient show more side effects also. So if talking about the median PFS, it was 5.8 months here, and with the 6.4, it was 5.5 months. So again, comparable PFS to the overall survival does show some differences, 13.4 with not reached here. But the problem is the side effects, they tend to increase a lot with the 6.4 kg body weight. And like I said, for any stage 4 cancer, the side effects becomes very important to decide your line of therapy. Now the important thing is the expression, the HER2 expression again matters here. We do see that the patients who are doing like the ISC expression, the stronger the ISC expression, though the responses might be seen with the ISC 2+, but again the ISC status, the 3+ do much better. The RAS stated, the mutant RAS, we label them as a very aggressive cancers, and we see that yes, the RAS status will actually impact your all kinds of therapies. The chemo responses are shorter, the targeted therapies responses are shorter, and some treatment options you actually cannot use if you have a RAS mutant type. Not much difference whether the left versus right side. In the colon cancer, there's a lot of talk between the left side and the right side, but we don't see a much difference here. And prior anti-HER2 treatment also does not make any difference here. So HER2 expression is prevalent in the range of solid tumors and associated with biologically aggressive tumor phenotypes and increased chance of recurrences. Destiny PAN-02 evaluated the efficacy and safety of TDXD in patients with HER2 expression, advanced solid tumor, and excluding the common ones, isn't it? And demonstrated clinically meaningful activity. The lung study approved the TDXD 5.4 mg/kg dose associated with favorable benefit risk profile. Okay, and reduce incidence of adjudicated drug-related ILDs. The safety of TDXD was observed and consistent with the established safety profiles. Biomarkers data support the need of validated clinical diagnostic tests, and this is where we need a lot of inputs from the pathologist, and consistent algorithm to score HER2 across tumor types outside of the biliary cancers, breast cancers, and the gastric cancers. Given the encouraging anti-tumor activity and durable responses, further research is warranted to better define which patients with HER2 mutations might derive greater clinical benefit from this particular trial. So that will be all from my side. If there are any questions, I'll be happy to take.
Thank you, Dr. Priya. Thank you, Dr. Priya, for that comprehensive update on the management of HER2 positive solid tumors. So, your talk clearly highlighted how the scope of targeted therapies has expanded in HER2 positive solid tumors, especially TDXD that you have highlighted, which is a newer therapy that is very helpful in HER2 mutated lung cancers, which is beyond breast and gastric cancers that we are aware of. And you clearly highlighted ki, knowing this genetic alterations is very important, not just the HER2 amplifications, but HER2 mutations is also important, so that appropriate targeted therapy can be given to the patient. Thank you very much, Dr. Priya. So we move on to our next talk of the webinar. And this talk is on the crucial diagnostic side of the equation in management of HER2 positive solid tumors. So, accurate HER2 scoring is key to identifying patients who can actually benefit from the targeted therapies. For the next talk, I invite Dr. Sunil Pasricha. Dr. Pasricha is a senior consultant oncopathologist from Rajiv Gandhi Cancer Institute and Research Center, New Delhi. He will take us through the nuances of HER2 testing and interpretation in solid tumors beyond breast and gastric cancers. Over to you, Dr. Pasricha. Please share your slides and
Thank you, sir.
you can start the presentation.
Yeah. Thank you, sir. Thanks for the kind introduction and good evening, everyone. It's a pleasure to be here with all of you. And first of all, I would like to thank the organizer for having me at this prestigious platform. So I can share my slides. Right. So my slides are on full screen.
Yes, Dr. Sunil, they are on phone screen. You can please
Okay.
go ahead.
Yeah. So I'll be talking about the HER2 scoring and interpretation in the solid tumors. So we know that HER2 is a transmembrane glycoprotein with intrinsic tyrosine kinase activity, which is encoded by a HER2 gene, which is located on chromosome 17. And HER2 signaling begins with the ligand binding and triggers the multiple downstream effects. And basically, it's the HER2 amplification or the overexpression that promotes the receptor homodimerization and heterodimerization, which causes the constitutive activation of several downstream pathways that eventually leads to tumorigenesis. Now, the benefits of HER2 targeted therapy has actually revolutionized the treatment landscape in many solid tumors, and the highest magnitude of the impact has been seen in the breast cancer, which is a very unprecedented. And the HER2 biomarker scoring criteria and the final result is different across the various tumors, as Dr. Priya has also alluded in her talk. And accurate evaluation and HER2 status is very critical to select the right patient who can derive benefit from HER2 targeted therapies. So, starting with the breast cancer, so we know that whenever a new case is diagnosed, it is subjected to biomarker testing and the molecular subtyping is done, of which the HER2 is a very integral part because HER2 positivity makes the categorization as a luminal B or HER2 positive category. So, and along with the staging and biomolecular subtyping, the treatment decision is made. Now, HER2 testing has actually evolved to improve the identification of HER2 positive breast cancer. The ASCO-CAP guidelines provide the algorithm to interpret the HER2 results from both from the immunohistochemistry as well as the in situ hybridization assay. And the first ASCO-CAP guidelines, they were released in 2007, which were based on the premise that it ensures the uniform and the standardized reporting across the globe and to ensure that the right patient receives the right treatment. And subsequently, as the clinical evidence evolved and emerges, there were some major updates. The next guidelines were released in 2013, and eventually there were some again major revisions, and then there was another updated guidelines released in 2018, which we are following till date. So, what's the criteria for the HER2 interpretation in the breast cancer? So, we label the case as 3 plus when there is a circumferential complete staining, which is complete, intense in more than 10% of the tumor cells. The 2 plus is equivocal when there is a weak to moderate complete membranous staining in more than 10% of the tumor cell. Negative, which is 1 plus, is incomplete membranous staining, that is faint or barely perceptible in more than 10% of tumor cells. And then IHC 0, which is less than this expression. So then we had a 2023 guidelines update, which actually affirms the prior 2018 HER2 reporting recommendation. So there was no change in the reporting guidelines. The only update was that the guidelines emphasized to do a due diligence in distinguishing the HER2 negative, that is score 0, from HER2 negative score 1 plus, because earlier the pathologist and even the medical oncologist, they don't grapple, to distinguish so hard between the 0 and 1 plus, because eventually they were together clubbed as negative. And why this became so important? Because of the encouraging results in the Destiny Breast 04 trial, in which the trastuzumab deruxtecan has shown to be effective in the patient with even low HER2 expression, which are actually defined as HER2 1 plus or 2 plus, which eventually fish negative for amplification. And the same thing was reinstated by NCCN guidelines in 2023, that the distinction between IHC 0 and 1 plus is clinically relevant. But in the last couple of 2 months in this year, 2025, we had three important recommendations from the three different international agencies, from the NCCN, the College of American Pathology, and the European Medical Agency. So they have now dissected the category of score 0 into two groups. One is the score 0, which is HER2 null. When there is no staining, it is totally bereft of any membranous staining. And the other category is the score 0 plus, which is the HER2 ultra low. So this is defined as when the membrane staining that is incomplete, faint, or barely perceptible within the less percent of the 10% of the tumor cell. The rest categories remains the same. And why it is important? Because of the encouraging results in the Destiny Breast 06 trial, in which they found that not only the HER2 low, but also even the HER2 ultra low, that is the 0 plus category, metastatic breast cancer, who has received one or more lines of endocrine based therapy, the treatment with the trastuzumab deruxtecan resulted in a longer PFS than the chemotherapy. So FDA has approved the FAM trastuzumab deruxtecan for the HER2 low, for the HER2 ultra low, as determined by the FDA approved test. So this is very important, that when we talk about the FDA approved test or the companion diagnostic test. So basically FDA approved test should preferentially be used for the trastuzumab or any HER2 directed therapy. And at our institute, we are using the pathway from the Roche as a companion diagnostic, which utilizes the antibody 4B5. And FDA has approved the pathway this for the use of the FAM trastuzumab deruxtecan for the HER2 low as well as ultra low. So when we talk about the FDA approved assay, it's not just about the antibody or the clone or the autostaining platform. It's about the chemical reagents, the pH, the antigen retrieval procedure, duration at each step, the chromosomes, whether you are doing amplification or you are not using, incubation time, and even the temperature control in each and every step. So it is an integrated, sequential, and complex series of these chemical reactions that gives you the end result for the interpretation on the slide. So coming to the HER2 scoring in the breast cancer, the positive criteria, it's very strict. You have to follow the triple C, that is in more than 10%, you have a triple C, that is the complete, contiguous, and chicken wire calcification. In chicken wire membranous staining, that is intense staining basically. For the HER2 to 2 plus, so basically 2 plus is a spectrum of a result. It is not a single entity. So anything which is short of 3 plus and anything which is ahead of 1 plus is basically 2 plus. So here you can see that some cells can show intense staining, but you cannot cherry pick. It has to be contiguous 10% of the areas. So this case was 2 plus, but subsequently it was found to be fish amplified. This is again a 2 plus with a moderate intensity complete membranous staining. And this is again a 2 plus which was fish subsequently non-amplified. And here you can see a complete membranous staining, but of a weak intensity in more than 10% of the area. So final interpretation will be a HER2 negative, HER2 low. So this is the HER2 negative, HER2 low for 1 plus. Here you can see there are incomplete membranous staining. It is not making a complete circumferential staining, and it is having a moderate intensity. This is a case of a metastasis in the lung, the CA breast that is metastasized to lung, and it was actually a score 0 plus, that is ultra low. And you can see that at low power, you barely can see a staining, but this one small focus is showing a very little hazy staining. And at high power, you can see there are some areas which are showing incomplete, faint, barely perceptible staining in this area. So this was actually HER2 0 plus ultra low. So the right microscopic lens is also very critical when you accurately assess the HER2 IHC score, because although HER2 3 plus and 2 plus, they are visible at low power, but for 1 plus and ultra low, they are not observable at 10x and they are best visualized at 40x. So you have to evaluate thoroughly at 40x when the requisition is especially for the ultra low. So, what are the practical challenges in the HER2 reporting, and what about the unusual scenario? So, as per the guidelines, all said and done, but we do get across some unusual cases. And there are guidelines that category of HER2 status can be encountered, which are not actually covered by these definitions. And in practice, they are rare, but if encountered, they should be considered as HER2 IC 2 plus equivocal, and one should go with the orthogonal testing with the FISH testing. So this, so I'm just sharing one of few of my cases from the case library. So this was a case of a clear breast, and here you can see intense staining, thick circumferential, but it is incomplete. You can see it's a cup-like U-shaped staining at many places. So it's not a complete staining. So we ordered the fish in this case, and that was amplified. So eventually it was HER2 positive. Another important aspect is the micropapillary pattern. So this many times, it shows a low grade morphology, but they can be very deceptive. And the threshold that you keep for giving an equivocal in a micropapillary pattern should be slightly low. So even if it is showing you a moderate intensity with an incomplete staining, one should label it as 2 and should always advise for the fish testing. And we have seen, this was our one of our publication, we have seen in the low grade tumors also, this was a HER2 positive mucinous carcinoma of the breast with micropapillary feature, which was HER2 positive. Another thing is the intratumoral heterogeneity. So this was a true cut biopsy we got, and you can see a glandular configuration. ER was strong positive, 100%. HER2 was negative, it was 1 plus. But in the resection specimen, we got some areas having a high grade morphology, which was just juxtaposed with these low grade areas. And you can see high grade ATP in the solid sheets. And when we did HER2 repeated in this case in the resection specimen, we found the HER2 positive areas in the solid areas, while the glandular areas they were negative for HER2 as it was initially in the core biopsy. So if the initial HER2 test in a core needle biopsy is negative, but on the excision specimen, if you found a higher grade carcinoma is observed, a new HER2 test that must be ordered, and even the ASCO-CAP guidelines also advocates this. Coming to the FISH criteria, so in 2018, the guidelines which were updated, we are following that guidelines till date, and there were two major some updates were there. So that there were two major changes. So in at our scenario, like in India, we are doing first immunohistochemistry. So all the cases which are 2 plus, they are ultimately subjected to the FISH testing. So there were two major changes. One was in the group 2 when the ratio is more than when the ratio of HER2 step 17 is more than 2, but the average individual HER2 copy gene number is less than 4. So this was initially considered as, in the previous guidelines, this was considered as positive, but with the recent guidelines, it is considered as negative. Another change was in the group 4. So when the HER2 step 17 ratio was less than 2, but the individual HER2 copy number is between 4 and 6. This was initially considered as equivocal, but now it is considered as negative. So it's very important for the pathologist that whenever there are changes in the guidelines, one should generate our data and publish this. And this was the first study from India that we published, and which showed the impact of the recent ASCO-CAP guidelines on the HER2 reporting category. And we found a substantial decrease in the ICP vocal cases that were statistically highly significant. And in the reflex fish reporting, with the adoption of 2018 guideline, a total of 5.6% cases from equivocal and positive categories as per the previous guidelines, they shifted to negative fish result category that was statistically highly significant. And also, there was an elimination of the double equivocal cases with the recent these guidelines. So coming to the gastric or the G-junction adenocarcinoma, the scoring criteria is different, which is advocated, and we adopt the Hoffman scoring criteria. So the criteria is different in the resection specimen. You can see in the left column, and it's different in the biopsy specimen that you can see in the right column. So the percentage cutoff remains the same as that of the breast cancer, that is 10% cutoff is adopted. But one change is the pattern of staining. Like in breast, you need to have a complete membranous staining, but in the gastric or the G junction adenocarcinoma, even a basolateral or a lateral membranous staining also qualifies. And for 3 plus, you need to again you can have a basolateral or a lateral membranous staining, but that needs to be intense and strong to qualify as positive. Whereas in the biopsy specimen, there is no percentage cutoff. You have to rely on a staining on the clusters. So if you have a strong intense staining in a cluster, even if it is complete basolateral or lateral, it qualifies for a positive HER2 test. And when we define a cluster, it is actually consists of more than 5 neoplastic cells, but that has to be a contiguous. You cannot cherry pick, one individual cell and you can make it a five total neoplastic cells. So it has to be contiguous cluster. So awareness of location and histology is quite helpful in HER2 evaluation. The gastric or the G-junction adenocarcinoma has a greater intratumoral heterogeneity than a breast cancer in terms of HER2 expression. The HER2 positivity is more common in the G-junction adenocarcinoma than gastric adeno. The intestinal histology is more likely to be HER2 positive than the diffuse type. And the well to moderately differentiated adenocarcinoma are more likely to be HER2 positive than poorly differentiated adenocarcinoma. So this was one of the case from my case library, and you can see here this is a gastric biopsy, and you can see there is a glandular differentiation over here. And when we did the HER2, the immunostain, you can see a strong positivity in those areas as compared to the solid areas. So FDA has approved the trastuzumab deruxtecan for the locally advanced or metastatic HER2 positive gastric or G-junction adenocarcinoma who have received a prior trastuzumab based regime. For a HER2 low G-junction adenocarcinoma, as of now, there is no approval, and the discordance rate between the percentage of HER2 low in biopsy versus rejection specimen is actually very high. As per the prevailing literature, it is 35% compared to 21%. And the range of percentage of HER2 low among the various institutes is also quite high, that is ranging from 19 to somewhere around 40%. Regarding the colorectal carcinoma, while the breast cancer and G-junction adenocarcinoma, they have established consensus guidelines for the HER2 reporting. For colorectal carcinoma, it's more controversial. And HER2 overexpression is identified in approximately 2% of colorectal carcinoma and is generally mutually exclusive of RAS or RAF mutation. And all in all, the HER2 positivity is seen in up to 5% of KRAS wild-type tumors. And the NCCN colorectal guidelines recommend testing all the metastatic colon cancers for HER2, with the exception of those that are known to be RAS or RAF mutant. Regarding the FDA approval of the drugs for HER2 positive colorectal carcinoma, the combination of tucatinib and trastuzumab is approved for the HER2 positive RAS wild type metastatic colorectal carcinoma that has been previously treated with the chemotherapy. And the trastuzumab deruxtecan is also approved for HER2 positive metastatic colorectal carcinoma that has previously treated with prior with the anti-HER2 therapy. So various anti-HER2 trials for colorectal carcinoma has been there in the literature, the Hercules, My Pathway, and Destiny, and all these have a different criteria for the selection of HER2-directed therapy. So what is advocated is even by the CAP guideline is that we are also using this scoring criteria is popularly known as the Hercules criteria, and this is the tabular the algorithm. I'm not reciting the each and every line, but just the positive criteria is that when you have an intense staining in more than 50% of the cell, which can be circumferential, basolateral, or lateral, it is considered as positive. And in this case, you don't need any a fish confirmation by this test. Whereas if the staining is in between 10 to 50%, it is considered as although 3 plus staining, but you need to confirm with the fish testing before you subject the patient for the therapy. So here the criteria, the cutoff criteria for positivity is 50%. In the female genital tract cancer, and especially the uterine serous carcinoma, the HER2 overexpression and the gene amplification has been reported in 30% of the uterine serous carcinoma, 16% of carcinosarcoma, and 48% of clear cell carcinoma. Currently, there is no randomized clinical data supporting the use of trastuzumab in gynecological malignancy outside the context of uterine serous carcinoma, and the current NCCN guidelines recommend HER2 testing in all the endometrial serous carcinoma and carcinosarcoma, and also to consider testing for all the P53 mutated abnormal carcinomas of gynecological origin, irrespective of the histiotype. The HER2 status appears to be associated with the abnormal P53 immunoexpression. So for the trastuzumab, the criteria which we are following is that in the endometrium is the cutoff is here is 30%. So for a positive score 3 plus, you need to have an intense complete, even a basolateral or lateral membrane staining will qualify, but the cutoff percentage criteria over here it is 30%. So trastuzumab is approved in combination with the chemotherapy for advanced or the recurrent HER2 positive endometrial cancer, including the uterine serous carcinoma. And in 2024, the FDA granted the tumor-agnostic accelerated approval to trastuzumab deruxtecan and HER2 for adult patients with unresectable or metastatic solid tumor with 3+ immunohistochemistry expression who have failed with the prior systemic treatment and have no satisfactory alternative therapeutic options. The point to emphasize is that for the trastuzumab deruxtecan eligibility would require only HER2 IHC with application of the gastric cancer specific percentage cutoff criteria without determining the gene amplification status in IC2+ tumors. So these are some of the cases. You can see the omental tumor deposit of the serous carcinoma. And here you see the staining. It is a 2+ staining. It's a weak staining, which is circumferential complete. So if the intent of treatment is the trastuzumab, it needs to be subjected for the FISH testing. But if the intent of treatment is trastuzumab deruxtecan, so this won't be eligible for that therapy because it needs only overexpression by IC3 plus by immunohistochemistry. This is another case, mucinous adenocarcinoma of the ovary. You can see the high-grade atypia as well as the intracellular mucin. And this was the P53, which was highly and strongly positive, abnormal P53 immunoexpression in more than 50% of the tumor cells, strong nuclear intensity, and this was HER2 3+ positive. So to conclude, the encouraging results from the various trials support the potential for expanding the role of HER2 targeted therapy across the variety of HER2 expressing solid tumors. The treatment landscape for the HER2 targeted therapy will continue to expand. The HER2 testing in breast cancer and other cancer will also continue to evolve. And applying appropriate scoring method and following reporting guidelines will be prudent. Participation in EQUAS and proficiency testing will be invaluable for reassuring the lab performance, and it's incumbent upon pathologists to make the testing reliable by optimizing the pre-analytical, analytical, and the post-analytical steps. Thank you very much. Would be happy to take any questions if you have.
Thank you, Dr. Sunil. So, as I've discussed, we will take questions at the end of the webinar if time permits.
Right.
And thank you very much for demystifying the challenges that are present with HER2 scoring, especially highlighting on the different scoring systems and their use in the other solid tumors apart from breast and gastric cancers for scoring of HER2 IHCs. So your presentation also highlighted the importance of validated diagnostic algorithms for stratifying patients across the diverse tumor types. So thank you, Dr. Pashricha, very much.
Thank you.
And now that we have explored both the therapeutic side from Dr. Priya and the diagnostic perspective from Dr. Sunil Pashricha on HER2 scoring, we would now proceed to a panel discussion that will bring both these viewpoints of therapy, management, and the diagnosis, that is the scoring of HER2 together. And for panel discussion, I would invite Dr. Milap Shah to be the moderator and moderate this panel discussion. Dr. Milap Shah is a senior consultant oncopathologist from Yashoda Hospitals, Hyderabad. And joining him as a panelist are Dr. Priya Tiwari. She is a medical oncologist from Artemis Hospitals, Gurgaon. Dr. Sunil Pastrija. He is an oncopathologist. We have already heard him talk just now. Dr. Vidya MN. She is a lead consultant histopathologist from Manipal Hospitals, Bangalore. And Dr. Vishwapriya MG, who is an oncopathologist from Mangalore Institute of Oncology. So over to you, Dr. Milap, for the panel discussion.
Thank you, Sushant. And now we have eminent pathologists across the India, and Dr. Priya is there as a medical oncologist on our panel board. So, as you rightly said, this is panel discussion is a combination of both the clinical utility and what are the current challenges we face as a pathologist and how to overcome. So we'll seek the guidance of our eminent senior pathologists and the medical oncologists, and we'll go step by step how to go through the HER2 directed testing in a solid tumor beyond the breast cancer. Can I share my screen?
Yes, please, Dr. Milap, share your
Yeah.
screen. The panelists are already there on screen.
Yeah, it's visible.
Yes, Dr. Milap, your screen is visible. Can you make it full screen?
Yeah, 1 minute. It's full screen only. Well, now it's full screen.
No, Dr. Milap, it is not in
One minute.
the full screen mode. Can you once again please try it?
Yeah, 1 minute. Yeah, this is full screen now.
Dr.
No,
Milap,
it
I
is
think
not
you need
in full,
to
but
go
I
to the
think we can
slideshow.
start. It is visible. We can
Okay.
start.
He can shift
It
to
is
the slideshow, maybe it will help.
It's there in the slideshow mode only.
fine, Dr. Milap. We can go ahead.
Okay.
The screen is visible. We can go ahead.
Okay, screen is visible. Okay.
Yeah.
So, 1 minute. So now we have seen that the with the first lecture, Dr. Priya has highlighted how the HER2 directed therapy in the current era has changed the clinical practice, because now the availability of the HER2 low directed therapy, or the newer molecules which can act on a HER2 low expression also. And Dr. Sunil has highlighted how to interpret the HER2 in a beyond the breast cancer, especially in the gastric cancer and the other cancer. So, first question to Dr. Priya, ma'am, in this scenario, what are the tumors you are actually interested in testing for the HER2 in beyond the breast? So, we have seen you have in your first presentation you have highlighted right from the biliary tract to the pancreatic to the cervical, the wide variant universe of the solid tumor spectrum is there. But actually, in current clinical practice, what are the actual system or a tumor you are more interested in testing for the HER2?
So breast cancer, gastric cancer. So I'm talking about the metastatic cancers. We have for breast cancer, we are also doing for the non-metastatic, but I'll just enumerate the metastatic cancers where we are doing it. So breast cancer, gastric cancer, colon cancer. You saw my result for the cervical cancer. Though the positivity is very less, but in cervical cancer, when the patients are positive, they show very good responses. So cervical cancers we have started doing. Mucinous ovarian cancer is something that we are doing it now. Endometrial cancers, in the serous cancers, we are doing it routinely. So these are the most common cancers. Gallbladder cancers also we are seeing that the patients are, especially see the gallbladder is I think very rare in the West. They don't talk about it. When they talk about biliary tract cancers, they talk about intrahepatic and the extrahepatic cholangiocarcinomas. But in India, in gallbladder cancers also we are seeing HER2 positivity. So these are the most common ones that we usually test for. But yes, if the patient has progressed beyond 1 or 2 lines of therapy, then almost all the solid tissue, and yes, salivary gland tumors also we are doing. So almost all the cancers will be actually happy to test and find if a target is, it's a target worthwhile exploring in all the cancers, especially in a later line of setting.
Okay, so if I understand, majority of the tumor what you have described, they are more likely adenocarcinomas of the various thing.
Yes, sir.
So,
Yes.
uh,
Sorry to
so
interrupt. Dr. Milap, sorry to
yeah,
interrupt. Actually, the slides are not changing. Okay. So is it okay that we share the screen
yeah,
from
that's
our
fine.
side and you
Yes, yes,
can,
yes, that's
yeah.
fine.
So just give us a minute. We will share the screen and then you can say the next slide and we will change the slide.
Okay,
Okay.
that's fine.
Shrikant, can you please share the screen so that Dr. Milap's presentation is seen as a full screen?
Yeah, few seconds, sir. I'll just projecting that.
So I'm extremely sorry for the interruption.
Okay, so meanwhile, while they share the
Yes, Dr.
screen, so
Minna, please go
yeah,
ahead. Meanwhile, we can take further questions.
yeah. So as Dr. Priya rightly said, that she is interested in a testing for the HER2 beyond the breast cancer, especially in the stomach,
Sir, let me
cervix.
know if my screen is visible. I projected it.
Dr. Milap, you will have to stop sharing your screen. So
Yeah,
Shrikant's screen is visible.
yeah.
Yeah, now the slideshow is completely visible. So Shrikant, can you please go ahead?
Good. Next week.
Next slide. Next slide. Yeah,
Next. Next slide.
yeah.
Yeah.
So
So
Dr.
now,
Milap, please continue.
yeah. So now, Dr. Priya is rightly said that she is interested in testing HER2, apart from the breast cancer in a gastric, ovarian, cervical, biliary, pancreatic. So these are the whole various spectrum of cancer are there, but we know that all the majority of the tumors they have a adenocarcinoma morphologies. So again, Dr. Priya, are you interested in doing HER2 in for a squamous cell carcinoma?
So, sir, in cervix, there is a data for the cervical squamous cell carcinoma. The positivity rate is around 4%. I think you can correct me there.
Okay.
So, in cervix for squamous also we are doing, and for see, I think the challenge is how to interpret it, where yeah, the panel can shed light. But for various other squamous cell carcinomas also, so esophageal squamous cell carcinoma also, the positivity rate has been reported to be around 4-5%. So in a later line of setting, we are doing in all solid tumors.
So the take-home message for the all the viewers is, so it's not only for the adenocarcinoma, HER2 testing is there for the all metastatic solid cancers beyond its histomorphological differentiation, whether it's adeno or squamous, you can go ahead, you can do it. Now, the next question to our pathologist, Dr. Vidya, is there with us. So, ma'am, how do you, why this gastric cancer is forms the basis for the HER2 interpretation in the majority of the solid cancer?
Yeah, so when we understand the HER2 testing, first it went all the way back to breast cancer, like how Dr. Sunil has already mentioned in his talk. And after that, we got the gastric. Why was there two different categories for analysis of both these tumors as being different? That is because gastric cancers are known to be really heterogeneous tumors, even when compared to breast cancers. That is first point. And they show incomplete staining rather than complete staining. So we have generally basolateral or lateral type of staining rather than complete membrane staining that we see in breast cancers. Why is this? This is because most of these tumors are gland forming tumors and most of them are adenocarcinoma. For example, if we take testing in endometrial cancers, they are again gland forming, cholangio's gland forming. We have various other like cervical adenocarcinoma, that's again a gland forming tumor. So G junction tumors are can be both squamous as well as adeno, but majority are gland forming tumors which show a different pattern of staining. And these heterogenetic staining and also the varying type of morphological interpretation of the staining pattern was observed first in the gastric cancer, and hence we had a different criteria for scoring. The second point is these tumors generally with the scoring pattern of gastric cancers that were followed was found to be completely concordant with the amplification studies that were done. And because of these reasons, the gastric cancer protocol was adopted for testing in the other solid tumors. That is the best possible explanation that can be given at this point in time. And similarly, maybe even for squamous, it may behave like a breast type of staining, but we are not aware. As and when we address more testing patterns and more cases are tested, we will come across a situation where we may have a different type of scoring. But right now, gastric cancer scoring is what is allowed for the other solid tumors as well.
Okay, so very nicely said that the gastric is now forms the basis for the interpretation of the HER2 IHC in a non-breast cancer across all the tumors. So the basolateral staining, incomplete staining, tumor heterogeneity. So these were the are the main reasons that we should understand that the HER2 interpretation is different in the gastric cancer and the other solid cancer as opposed to the breast cancer. Now, next question to Dr. Vishwapriya and Dr. Sunil. Now, we would like to your thoughts that what happens if we say still use the breast cancer cutoff in the for the gastric cancer or other solid cancer, then whether we'll miss or we have a many false negative or what?
Yeah, we will be definitely missing. The basic difference is it's for breast cancer is complete strong membranous staining, but for gastric and gastroesophageal junction it is complete or basolateral or basal. So if we have to take the breast criteria that is complete strong membranous, we are going to miss a lot of cases. HER2 positive cases in gastric and gastroesophageal. So we need randomized trials which will set up, give out criteria, interpretation criteria for HER2 in different tumor types, solid tumor types. We cannot be juxtaposing the breast cancer criteria onto other tumors.
Okay, so very nicely said. Now, Dr. Sunil, in current scenario, do you face any sampling issue while performing the HER2 testing, especially in the gastric cancer, considering the tumors are more heterogeneous and what kind of quality of the biopsy you want to avoid this heterogeneity and to avoid the false negativity, especially in the gastric cancer? As you know that the majority of the gastric cancer are in the advanced setting and the biopsy accessible is very easily accessible by the gastroenterologist. But is there any challenge or sampling issue do you face?
Yes, yes. So even I told this thing in my PPT also, like in my presentation, that whenever we are, because as a pathologist, we are going to select the section or the block for giving the HER2 staining. So we have to take the section which is showing areas of, well to moderately differentiated areas, some glandular differentiation is there, or if it is showing some intestinal type of morphology. Because the probability of getting HER2 positivity in these areas is more as compared to the diffuse type or the poorly cohesive carcinoma areas. So while giving the section, we should give the section having a well to moderately differentiated area.
Okay, so the take-home message from this is while we perform the IHC, is the pathologist's job to choose the correct block. If the tumor is showing heterogeneity, if it is showing poorly differentiated tumor, but at some places in another block it is showing well to moderately differentiated adenocarcinoma, it's ideal to test the HER2 on the both the blocks, because as the Dr. Sunil rightly said that the well differentiated and the intestinal type morphology are likely to have a more evidence of positivity for the HER2 as opposed to the poorly differentiated carcinoma. Srikant, next slide. Okay, so this is again the recap. There is a difference between the breast and the gastric while interpreting the HER2 as opposed to the complete membrane. We accept the basolateral staining in the gastric biopsy and the other solid cancer, and simultaneously the cutoff is 10%, but for biopsy, even a cluster of one cluster or more than five tumor cells positive is also considered as a positive. Next slide. Again, so in the current scenario, now Dr. Sunil has rightly highlighted in his talk that the FADER and Heracles scoring criteria are available, especially for FADER for the serous cancer and Heracles for the colon cancer. What is their current utility in the era of the HER2 directed therapy, in the newer HER2 directed therapy, especially when you are seeing the TDX and the availability of the TDX in the in India. Dr. Sunil, your thoughts
Yeah.
on?
So basically, the utility of the scoring is basically it's based upon the clinical utility of the assay. So the scoring has to be correlated like that at what particular threshold cutoff it has shown a good clinical response in the clinical trial. So on the basis of that, they have made a different cutoffs in the various. Like for the colorectal, the criteria is 50%, but for the uterine serous carcinoma, it's 30%. So it's the meaningful clinical utility of these cutoffs that is more important. So on the basis of which they have proposed these cutoffs in the various the scoring
Yeah,
system.
Dr. Vidya, your thoughts?
Yeah, so like Dr. Sunil mentioned, the FADA criteria is what is adopted for the trastuzumab treatment. At least that is what we are going to see in the resection specimens and even maybe the biopsies. But when we come to the TDXT use, the CAP has given a separate guideline, which is similar to the DBO2 trial, that is for our other solid tumors, where they've adopted the gastric criteria. So when we know that the clinician wants to use the TDXT in that particular case, then we'll have to change the scoring pattern. When it comes to heracles, I have my own reservations on this because the DBO2 trial again took into consideration even for colorectal the gastric protocol. So as we know that colorectals are hardly 1 to 2% of cases which are going to be HER2 positive. So if we are going to put in the heracles criteria, we're going to lose those patients also, because 50% is a huge cutoff figure. And when we see the small biopsies, it would make sense in adopting the gastric scoring pattern here as well. And we
Dr.
also
Vishwa.
know that Heracles is quite complicated in terms of scoring, and without a reflex test, it is impossible to give out a correct scoring.
Yeah. Dr. Vishwapriya, your thoughts?
Yeah, I just had a, because sometimes I do get a request from my oncologist also for HER2 on metastatic, in metastatic settings, in after maybe failure of one or two lines. So this is a question again from my side to Dr. Priya, Dr. Vidya, Dr. Sunil. So what would you recommend? Would you recommend the original tumor block or the metastatic site to be evaluated?
So I think
So,
it should always be the most recent, the block, preferably. But if it is not available or the biopsy is not possible or the patient is not in a condition to undergo a biopsy, then the previous blocks can be used. But as far as possible, the recent should be the most useful and most informative. I think
So,
other
so
panelists can also give their
yeah.
views.
Dr.
Actually,
Priya?
metastatic side is something that I'll prefer.
Okay, and
Yeah.
again, this is to Dr. Priya. Now you have seen that the various views of the pathologists regarding the Feder and Heracles scoring. So, while you send the request for the HER2 testing, so what you expect from the pathologist? So, it's not about the cutoff, it's not about the criteria name. So what you want us to see while you say, okay, I want the HER2 testing especially for the ovarian serous or the for the colorectal cancer.
Sir, so whenever we send this a sample beyond breast and gastric, so always when they write 3+2+1+, so we are already this is a very common discussion that what is the criteria they are using and what confident are they. So it becomes a very common discussion. But if when they are confident, they are clear cut something. See, there are a lot of cancers where I think even the pathologists are learning, isn't it? So where and we are also using a lot of NGS. So we do see mutation, but yes, we also see a lot of surprises there. So this is what we expect from pathologists, that if not known, they should also discuss between themselves, be confident about their reporting, and give us a clear cut reporting.
Okay, thank you. So
And I think one, Milad, I just want to add one
yeah,
thing that I think now the requisition should also include the not only the organ or the type of test, but also the intent of treatment, because the scoring positivity cutoff criteria for trastuzumab is different for the trust and as compared to trastuzumab deruxtecan. So the intent of treatment should also be, I think, now mentioned in the requisition, because the
correct.
positive criteria will be different.
Yeah,
Yeah, I
so
agree very much with Dr. Sunil on this, because if they give us a prior idea, then we'll know which is the exact scoring pattern to be used. And to Dr. Vishwapriya's question, I always prefer doing the IHC on both metastatic setting and the tumor block as well as the primary tumor, because it is going to show some difference. I mean, I do it mostly out of curiosity, but we have come across a lot of differences in terms of the HER2 staining, because you can have variation in your HER2, like primary could have been a 1+, then it may be a 3+ on the metastatic setting. So you need to do, and like Dr. Priya mentioned, it is better that we do on the metastatic front, because that is what is having a molecular change probably.
So I had a
okay.
case where we had a gastric cancer in a G junction adenocarcinoma. So they requested failure on one line of therapy. They requested for HER2. Patient had ascites, malignant ascites. That the HER2 was negative on the primary tumor, but was positive on the cell block.
Yes.
Okay. So,
So how do we go about doing that?
No, and this is the common practice. So, patient operated for CA breast, ER/PR positive, HER2 negative, then comes some years later with the liver mets, and that is positive for HER2. I think all of us
Yeah.
would have encountered that.
Yes.
yes,
Yeah, the
correct.
upregulation of HER2 is more common and downregulation of ER is more common in the
Correct.
subsequent metastasis that we have
Correct.
seen in our experience
Metastatic
also.
side is something that even I'll actually.
Correct.
Yes.
So, take home point from this discussion is that the Feder and the Heracles criteria were based on the conventional HER2 directed therapy or the trastuzumab era, where you need to have a very high percentage of positivity to have a meaningful response. But now, in the era of the TDXD, the cutoff has brought down from the 50 or the 30% to the 10%. So, that's why
10%.
we all follow the gastric cancer criteria. So, next slide. Next slide. This is the same that we have just discussed. Next slide. Okay. Now we know that we have seen from your first your Dr. Sunil your lecture that the okay how to interpret the HER2 by the IHC. Now there are certain area where you feel the difficulty while interpreting the IHCs. So it is similar just like the breast cancer. So while you have a 2+ scoring in gastric cancer, how do you want to resolve this ambiguity? Or what do you want again to prove that okay whether this is HER2 overexpress or HER2 amplification is there or not?
So for that we have to so if it is a 2+, if it is a equivocal, we have to go for the orthogonal testing, that is the HER2 fish we have to do.
Yeah, Dr. Vidya, is there any role for repeat for IHC or doing the IHC if not done on the Ventana or on the this one Deco platform like Hercept, or do you want to use this validated antibody, or you just want to go for the directly for the fish?
No, I would prefer testing it again on a validated platform. And especially, this is going to come very often from the clinician. They will have a doubt when it is a lab derived test. So, that is when they ask us to retest it. And if IHC is good enough, then there is no need of doing a fish test. But otherwise, if it is going to be an equivocal result, fish test will be required. Better to do it on an FDA approved platform.
And again to all the three panelists. Okay, so now we know that the fish is indicated while we have a ambiguous or the score 2+, especially in the gastric cancer. But do you get any request for the non-breast, non-gastric cancer to do the fish?
Yes, we do it.
Yes,
We
we
do
do
get
that. Yeah.
equivocal results. So when there is a 2+ result, we definitely do the fish test.
We are
Okay, so
sending that request.
even for the endometrial, cervical, or whatever cancer are there, 2+, maybe you are doing, but still, if there is no clear-cut NCCN guideline or a CAP guidelines are there for the fish testing in apart from the breast and the gastric cancer, but they can be used for the data generation and the research purpose also. Dr. Priya, your thoughts? Or do you want us to do HER2 by fish or HER2 by NGS or
So
in
the thing
a
is,
beyond?
I think the NGS is still evolving. We are still learning about the role of NGS. So we don't order NGS just to see HER2 other than the
Correct.
lung.
Okay.
But we do NGS because we want to see all the other mutations happening, isn't it, sir? But
Okay.
yes, we order fish because we know that if like suppose if somebody has some kind, like if I talk about gallbladder cancer, if you take an example, and I know that there is some data now for the trastuzumab in a later line of setting in gallbladder cancer, but I know that the trastuzumab will only work if it is ISC 3+ or fish positive in case of ISC 2+. So there I would request a fish if it is 2+ case, isn't it, sir?
Yeah.
And Dr.
Doctor,
Milan,
So
Yeah.
this I'm
So
talking about the gallbladder.
So main
Doctor,
is that when
yeah.
NGS is we have to understand that there is a HER2 protein level expression on the
Yes.
cells, then there is a HER2 mutation, and there is an HER2 amplification. So
Okay.
there are three different things. So NG fish will diagnose, will help us detect the amplification. NGS will tell us about the mutations, and you have copy number variation, which you can use NGS to tell if there is an amplification also.
So this
But
is what I'm saying. If just HER2, if I just need an HER2, in the cases where I feel there is ambiguity in ISC, then I will just order fish. I
yes.
generally don't order HER2 NGS for HER2.
Yes.
Correct.
I
So,
still see all the other mutations.
correct. So it's a part for of the along with the other tumor agnostic and
Yes,
the
yes,
prognostic
yes.
marker. So HER2 should be so. Again, the take-home message is that those labs or wherever we are sending or wherever in-house facility is there, HER2 should be a part of testing in the NGS panel. Another thing, those who are doing the fish testing, do you feel the HER2 on a fish or the in situ hybridization by this, is there any difference or challenges you face different from the breast cancer? Dr. Sunil, Dr. Vishwapriya?
Yes, the criteria are different. For example, if you see for the breast cancer, the criteria for fish positivity is that first you have to follow the algorithm. You need to have the ratio of more than 2, the HER2 to Sep17, and subsequently the individual HER2 copy number should be more than 4 now to give a test as a positive. Whereas in the gastric cancer, there is no significant role established for the Sep17 monosomy. So here the criteria remains that if the ratio is more than 2, you don't need to bother about the individual HER2 copy number. If the ratio is more than 2, it straight away you can label it as a HER2 positive. That's
And
the difference between the gastric and the breast.
Yes.
Dr. Vishwapriya?
Same. So
Yeah.
the
So
pain is that we don't have criteria which have been laid out very clearly, like the ASCO-CAP guidelines for breast. We have clear-cut succinct directives which have been given out, but we don't have it yet for solid for HER2 testing in other solid tumors.
yeah, so take home message for the viewers are the HER2 by fish on a gastric cancer is a different from the breast cancer and the cutoff is 2. So we don't see the SEP17 individual number to as we see in for the breast cancer. Now again to Dr. Priya. So now we have seen the HER2 by IHC. Just now we have discussed HER2 by the fish in the gastric and the other cancer. Now, what are your thoughts? What is important for you, especially for the therapy, whether it's amplification, mutation, or IHC overexpression?
So you're talking about the lung cancer?
First lung cancer and also for the other solid cancer also.
See,
So
so
how
for
do
the lung cancer, the data has evolved more so for HER2 mutation.
yes. And for other solid cancer, what will you take? IHC,
For,
fish, or
yes.
NGS?
So for
Uh,
rest of the cancers, it is basically ISC based. And for various other drugs also, it is ISC based approvals. Like there's a drug called as zenitubumab. That is the ISC 3 plus across biliary tract cancer, across this biliary tract cancer, yeah, and gallbladder cancers including. So that approval is ISC based. So in
okay.
most of the cancers, it is ISC based. In actually, I think in lung cancer only the approval and the TDXD data basically is the mutation based, the mutation testing based. But having said that, suppose if the patient has exhausted all the options and we do NGS to find out all the other target therapies possible, and if I see that there is a HER2 mutation present, I'll definitely consider that and use a targeted therapy.
Okay, so now we have seen that it's not only the IHC, it's not only the fish. Now there is a role for HER2 mutation is also there, especially, and the approval is there for the HER2 mutation direct if it is there in the NACLC. Now, Dr. Priya, again to you. So, if you see that the metastatic carcinoma or advanced solid cancer malignancy, and you send the patient for the biopsy to the either the radiologist or the intervention pulmonologist. Now, you want to do the wide batteries of tests right from the PDL1 to the MSI to the comprehensive genomic profile. So, what message you gives to your the intervention radiologist or the pulmonologist or gastroenterologist to make sure that you get the adequate sample for the all the tests?
Sir, she's a radiologist, the message is clear. So suppose if I am doing a repeat biopsy, it should be from the site which has progressed, isn't it? So there might be some old disease there in the scan, okay, and there will be some new sites of disease there, isn't it? So the discussion is that if I need a fresh biopsy, I need it not from the old lesion, I need it from some lesion which has actually shown a progression.
Okay,
So
so
that's so
yes.
they need to look at the old slide, they need the old scans, they need to look at the new scans. So that is something very important because we now doing repeated biopsies, we are doing repeated NGS to gather information about the cancer's mutations happening, isn't it? So that is the single most one. The one practice now that we have actually started inculcating is we are also doing a lot of liquid biopsies. The best is to get both solid and liquid. You tend to get some mutations there, extra something mutations there, but it costs a lot of money. But I think eventually that is where the world is going to ahead during the treatment progression, disease progression. Doing both solids and liquid. There are now platforms doing AI-based PD-L1 assessment in the liquid biopsies also.
Yes, correct. So again, the reverse scenario, now you have a single block, patient has come from outside for your opinion, biopsy proven, already done. Now, how do you fit the HER2 testing? When you want to get done the whole batteries of tests, right from the PDL1, MSI, P53 and the other molecular markers. So whether it's a part of your routine practice to do HER2 by IHC or a fish or by
So we actually, so that depends upon what was the initial cancer, isn't it?
Hmm.
There are certain cancers, you know that the HER2 targeted therapies with the HER2 expression is seen. Like suppose it was a breast cancer, we don't want to miss a HER2 by IHC, isn't it? So suppose it was a breast cancer tissue. So it will very much depend upon what is that particular tissue site. But yes, where I know that the patient has progressed beyond multiple lines, I would definitely not want to miss on NGS. So I would need to preserve that tissue. So it will depend upon the scenarios and the kind of cancer that the patient has.
Okay. Now, Dr. Vidya, what are your thoughts and what is your experience while doing the performing HER2 on old archival blocks versus the fresh sample? Is there
I
any
would,
difference?
yes, there will be a difference definitely, and especially for blocks which are older than 2 years and all that, we may get false negative results most often. And I would definitely prefer the fresh sample to do the testing. And if required, maybe compare both, but fresh sample is always ideal.
Dr. Vishwapriya, your thoughts?
It's muted.
You are on mute, Dr.
You
Vishwapriya.
unmute yourself.
Yeah, so I have problem when I encounter problems when I get blocks from peripheral labs where the primary tissue processing is not may is a issue, or when the blocks or the fixation is an issue. But mostly if I know it's an in-house block, I know I'm perfectly good for a year or two old block works well. But mostly I face issues when dealing with blocks which I get from peripheral labs. There the biopsy has been done in a peripheral lab where the tissue processing may not have been as per guidelines or as per this. So I do face problems there, but mostly it's manageable. End of the day, it's manageable.
Okay, so this is the take-home message for the medical oncologist that the many of the times you should not rely on the older blocks, especially because it will lead to the false negativity, especially where the storage condition is poor. So, as far as possible, if we have a fresh biopsy, it's always better. Next slide. So, as we have rightly said that, and we have rightly discussed, so IHC is different, amplification is different, and the mutation is different. And Dr. Vishwapriya has highlighted nicely that IHC overexpression of the protein is measured with the IHC. Amplification you can get done by the fish, and the mutation and the copy number variation it will be done on by the NGS platform. But this is for Dr. Priya and all the medical oncologists that while you do the NGS testing, here in the NGS we only have a data regarding the mutation. Sometimes if they have a good bioinformatics pipeline, then they'll give you the copy number variation and they'll give you the amplification. The only thing is that it's not the always all amplified tumors have a high protein expression by IHC, and you know that the drug has a effect, has a good effect while the tumor is expressing IHC 3 plus. So maybe what are your thoughts, or how many cases you want again while your NGS is negative by the fish, NGS is negative for the HER2 amplification or CNV copy number variation or mutation, then do you advise the retesting of that block with the IHC, or how do you want to go about this?
So like I said, in most common cancers now, like I reiterated so many cancers. So we are actually doing ISC in a lot of cancers now. Like even in cervical cancers, we are doing HER2. So by ISC, so actually we are including in a lot of cancers. And later on, we'll add NGS to our this. And where we find that ISC is 2 plus, then only we just go by a fish-based amplification. So I think now the question is whether is there any place where we are not doing ISC and we should do ISC? I think at least in my practice that is not the case. We are actually doing ISC, especially in the later line of setting, in almost all the cancers.
Dr. Sunil, your thoughts? Uh,
Yeah.
do you get the request after doing NGS? Kindly do HER2 by IHC when the NGS is negative?
No, I think we get initially, it depends upon the tumor type. Like initially we get for the IHC basically, and see the for the NGS we are getting the requisition only for the lung actually, for to detect the mutation, because and for the overexpression and the amplification we are getting the requisition by the IHC, and we have a reflex fish mechanism at our institute we have. So after NGS, again a request for the IHC, well, that's very unusual scenario at our institute.
Okay. Dr.
See, I just
Vishwapriya?
want to just make a
Yeah.
comment here, sir, and maybe take your suggestions also. So I have this patient of neuroendocrine tumor, like small cell variant of bladder cancer. Okay, now the patient was treated with chemotherapy. There's some data of immunotherapy. Patient progressed on that. Okay, and now in neuroendocrine tumor, there is no clarity regarding the ISC of HER2. So we did order the patient NGS, and in NGS there was HER2 mutation present. Now the question is whether I'll give this patient TDXD or not. So we went back to pathologist. We asked what is HER2 expression by IHC. She said HER2 expression by IHC is 0. So there is a mutation in the NGS, but there is no ISC. So now even the guidelines are divided. We don't know how to treat. But because across many other cancers there is some data of TDXD in HER2 mutation, so we put that patient on TDXD. He's due for the second cycle. But yes, in such a case, maybe I will do an IHC too.
So, as you rightly
Dr.
said, Dr.
Milap,
Priya, yeah,
Dr. Milap, sorry to interrupt. We have another 7 minutes left.
okay,
So I
no
would
issue.
request you to
We'll
go through the panel
yes,
questions
yeah.
and
So,
individually ask questions pertaining to the panel discussions
definitely,
to the
definitely.
panelists.
Yes. Now, so now, Dr. Vishwapriya, your thoughts. So many of the labs, those who are doing the HER2 in-house and those who are not having the validated platform or a Ventana or a DECO platform. So how do you want to make sure that, okay, they'll have a good quality HER2 result?
So I have less experience of using the manual method. So I'm not pretty sure of there are about guidelines of HER2 testing using manual methods, but I can the pre-analytical parameters are something which I always which are the cold ischemia time, the fixative, the duration of fixation, that is the 10% neutral buffered formalin, the fixation time, that is at least 6 hours, not exceeding 72 hours. So these are the things which I emphasize on. But about manual testing, there are actually, I don't think there is anything I know of where you have any guidelines on manual testing, because it's individual. It's quite it's objective for every lab, for a person who is doing the IHC via manual method. The antigen retrieval, the incubation, everything is different. It's not or not an automated platform. So I have my reservations of interpreting reports IHC done by manual method, especially if it is of therapeutic implication like ERPR, HER2 or anything. I would be very wary of interpreting anything which is done on the manual platform.
Dr. Vidya, your thoughts, how do you make sure that the lab should validate the HER2 while testing?
Yeah, so I do agree with Dr. Vishwapriya. I think most of us have moved from manual to automated platforms, but still there are labs in India which do the manual testing. So according to the CAP guidelines, these will be considered as lab-derived tests, and they have to do extensive validation of at least 40 positive and 40 negative tests. And these should comprise, especially now since this is a talk on HER2, they have to have an array of case of 0, 1 plus, 2 plus, 3 plus, and now they should also include the 0 plus because of the ultra low status. And then they have to send do a reflex test, that is with fish, to confirm what exactly is the score. That is how the actual validation has to be done in their labs, and this is an extensive part of the validation that they need to do. Also, at the same time, as part of the good lab practice, it would be advisable to run control on every slide. So if not an array of 0, 1 plus, 2 plus, 3 plus, a minimum of 2 plus, an equivocal control has to be put on all the sections so that they get a good result. So manual testing generally happens as a batch control, which they should avoid and make it as a slide control, like how we do on our automated platforms. This would be my recommendation for the labs which are doing manual tests.
So
Thank you,
what
doctor.
we have made a tissue microarray actually, where we have a negative 0, 1 plus 2 plus 3 plus a small tissue microarray which runs on every slide. So it becomes good. So you have an internal control, kind of an external internal control, whatever you can call it, external control, which is on the same slide. So interpretation, you are more confident in interpreting that slide.
Yes,
Yeah.
and this
So
is what exactly happens in your UK ECAS or your Nordic QC program. So you need to have your array of controls, and your controls are also assessed on these programs. So if it is better that for the labs to participate in these peer review programs, always external proficiency testing has to be done, interlab comparisons, internal peer reviews. Now because 0 plus and 1 plus ASCO cap recommendation is that pathologists have to review the slide independently for these scores of ultra low and low. So these things should be taken care of as part of good lab practice in the laboratory.
So thank you, Dr. Vidya, Dr. Vishwapriya, to highlight the what are the good practice while interpreting and performing the HER2 testing. Next slide. Okay. So again to Dr. Priya, medical oncologist. So now many of the pathologists face the challenge that many of the guidelines are not available in the CAP while you ask the do HER2. So what do you expect us to make sure that the how the pathologist should move from the stick to the CAP guidelines, or they follow the latest NCCN guidelines, or the current clinical trials what you are interested?
Sir, so if I want to use the drug to give the benefit of the drug, I want a report, isn't it? So even
Yes.
if there are no CAP guideline, I would want an answer.
Correct. So take a message for all the pathologists is that don't just stick to the CAP guidelines. Discuss with the medical oncologist, update our knowledge as per the latest NCCN guidelines and the current clinical trials. Next slide.
So yeah, what I would do is sometimes for sometimes I do get some very out of the box requests, maybe a HER2, maybe a c-kit, and where there are no guidelines. So what I do is sometimes we have clinical trials which have used cutoffs or criterias while recruiting or as part of or they have where they have used different criterias for allocating the patients to different arms. So I use those, I can quote or I can cite those trials and try to interpret the IHC. That's also completely valid, I guess. If you don't have a CAP guideline, but if you have a good trial where they have given you cutoffs for different, you could use that.
Yeah. So thank you. Next slide.
Dr.
Srikant,
Milan?
next slide. Yeah, next slide, Srikant.
Yeah,
Yeah.
I think we can go to the last two
Yeah, we
slides
can. Yeah. So these
because
are the
these
things
questions
already we
are,
discussed.
yes,
Yeah. So
already been discussed.
so we
I
have
think this
discussed.
is more important for a discussion over here.
Yeah, correct. So now again, this is the open. This is the last question to all our panelists. So how do what are the current unmet needs or challenge you face which hinders the decision making in a HER2 directed therapy in a solid tumor? We'll start with Dr. Priya. So in your practice, what are the most important challenges, one or two, what you face while even you want to give the newer HER2 directed therapy for your patient?
Sir, so one of the basic challenges we see discordance in HER2 ISC reporting.
Okay, very nice. So again, the take-home message is training, 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 update, good clinical and the good lab practice. Dr.
Yes.
Sunil?
Yeah, I think the standardization is important in the form of the testing platform. Like one should always use a companion diagnostic. So I think that will resolve the problem of the, and as you have said, the proper training. Of course, the proper training and the companion diagnostic will resolve all these problems of, the the different reporting basically.
Dr. Vidya, your thoughts?
Yeah, so first of all, awareness amongst pathologists and oncologists saying that HER2 has become tumor agnostic. So that is one big thing. And I feel that there should be a strong interaction between the pathologist and the oncologist, basically on what is the HER2 scoring pattern that we are giving and whether we are going to include any references and whether they agree with that for the particular drug that they are going to use. So that is one big thing. And for us, we are finding big challenges in terms of 0+ scoring. That has come into picture. The accuracy with which pathologists in the lab, the inter-observer variation is a little on the higher side, between this 1 to 9%, and especially the borderline cutoffs. So somewhere here, definitely we will require to consult our colleagues and also maybe take some external help as well.
Dr. Vishwapriya, any role of digital imaging or the AI for the
Oh,
to
it's
overcome
coming up
these
everywhere.
challenges?
Yes, yes, you have everything. You have AI coming in everywhere. So yeah, it will be there, especially for these 0+ and 1+. I guess 0+ and 1+. AI is going to help, no doubt. Whole slide scanning followed by AI will be a better test, because mostly we end up, however, whatever criteria is given, we most of our interpretation, for me especially, is more of an eyeballing type. I do not hesitate to say that, because as per so that's what I will. So, but maybe AI can be maybe it can stick to criteria more steadfastly. Maybe I
Yeah.
guess AI is going to be there.
Next slide. Okay, so now the take-home message from all our this talk is okay. So gastric criteria forms the basis for the all other solid cancer while interpreting the HER2. HER2 is not only interpreted with the IHC, there is a rule for the fish. Now for the lung also, you have an amplification also, mutation also. So IHC, fish and the NGS, all three methodology forms the part. And as Dr. Priya, Dr. Vidya, Dr. Sunil and Dr. Vijay all said that the current challenges are not only the testing availability, it's about the harmonization, it's about the training, it's about the quality, it's about the good lab practice. So these are the things we need to ensure first, and we need to adopt and we need to train ourselves in the AI and the digital banking to overcome this challenge. Yeah, thank you everyone.
Thank you, Dr. Milap, for the interesting panel discussion. Thank you to all our speakers, Dr. Priya, Dr. Sunil Pasricha, Dr. Milap Shah, Dr. Vidya, and Dr. Vishwapriya, for this engaging and insightful session on HER2 scoring and interpretation in solid tumors. Many of the remarks that are interesting, and I suppose all the delegates would have gained a lot of insights from this talks on HER2 scoring and interpretation in solid tumor. So, as we are short of time, we had few questions, but I think we will have to skip them. And for concluding this webinar, I would request and invite Dr. Soumya Ranjan Malik for the vote of thanks.
Uh,
Over to you, Dr. Soumya Ranjan.
Thank you, Dr. Sushant. Let me thank the Molecular Pathology Association of India and collaboration with AstraZeneca for providing this opportunity. My sincere thanks to all the speakers, Dr. Priya, Dr. Sunil, Dr. Mila, Dr. Vidya, and Dr. Vishwaru for accepting our invitation and part of this educational activity for the disseminating knowledge regarding photo news scoring, interpretation, the lab requirement, the and what's the new, what's the unmet needs currently for the labs, and which we can help and our oncologists for the better for the patients. So to summarize, I have 2 3 points I like to highlight for all. Like HER2 expression is prevalent in range of solid tumors. It is much more beyond that what we know traditionally breast carcinoma and gastric carcinoma. Data supports the need of validation of clinical diagnostic test and consistent algorithm to score HER2 across all type of solid tumors. ASCO-CAP gastric guideline may be a bridging right now for the solid tumor reporting. So There's lots more way to go ahead, as many of the panelists highlight, because those who are using the manual platforms, how to exactly report this, because we know our country is not everybody, every hospitals, medical college can't afford this FDA approved test like Ventana or Leica. So we need to have to help them how it is really they can, even if they are doing manually, how they can be helpful for the oncologist. Thank you all again. Good night to everyone. And those
Dr. Soumya Ranjan. So with this, we end the webinar. Thank you. Thank you very much.
Thank
Thank you
you.
all.
I
questions
learned a
we'll
lot.
try to answer later
Thank you
on
very much.
to everyone.
Thank you.
Good night, everybody. Happy Saturday and Sunday.
Good
Thank
night.
you. Good
Good
night.
night.
Bye.
Good night, everybody. Thank you.
Thank you, Dr. Susan.
Thank you, sir. Bye, sir.
Thank you,
Good night,
Dr.
sir.
Soumya.
Bye.
Good
Bye,
night.
sir. Bye, sir.
Good night.
We request all the participants to kindly fill the feedback form. I repeat myself, I request all the participants kindly fill the feedback form which was given in the chat box.
Recording saved now.
We request all the participants kindly fill the feedback form which was given in the chat box. The participants who has given the feedback kindly leave the session. Thank you.